So today, three things that we're going to get from hopefully today's webinar is insight into best practices on RCM workflows from the beginning, registration, all the way through patient collections and beyond. We're going to learn how to use some automation and AI tools to kind of speed ourselves up, gain some more efficiency. And then we're going to talk about how to grade ourselves using some benchmarking and data to understand if what we're doing is successful. So let's start by talking about what is revenue cycle management. And a lot of times folks think of rev cycle, they think of just back office stuff, starting with maybe claims and denials, appeals. It's a lot more than that. It's the full revenue cycle from the moment we first speak with and interact with the patient all the way through the very end where we're collecting balances and doing KPIs and reporting. So today we're going to kind of touch on each area of the revenue cycle that you see here. So what are the top challenges that we face? What are we up against and why is this important? It depends on what year or what survey that you look at, but this is generally the top 5 challenges that we're facing. Several years ago, hiring and training staff was probably number 1 because we had COVID and all the challenges that came with that. Patient collections has always been an issue, especially the rise of high deductible plans and coming up with ways to educate patients on what they owe out of pocket and collecting that, what tools do we use? And then also, security and compliance has always been a challenge. It doesn't go away. If anything, it gets harder and harder. And we remember, what was it, last year, a couple years ago, we had the huge breach with the clearinghouse and how widespread that was. So that's never going away. So there's 3 kind of main themes of the best practices webinar that I'm going to kind of touch on today. And the first one is let's look at the process. Let's map the process. So what are we doing today? So, and be thinking of this as we go through. And this is just going to be just a general conversation that I'm going to be having. So imagine we're just sitting in a room together chatting about RCM, and I want you to be thinking about what do you do today for this current process, whether it be patient registration, claims, charge capture. And, is this information documented somewhere? If you have a staff, is it shared with the staff? And if it isn't, let's get it down on paper. How often have you been worried about a process or procedure and then you felt better about it once you put pen to paper and you mapped it all out? So start with that. Then let's analyze it. Let's say, are there areas of improvement, things that need to be reanalyzed about our current process? And then do we need to do any redesign of the process? Do we need to reallocate resources? Do we have enough staffing, for example, to handle what we're trying to accomplish? And then once we've nailed all that down, how do we implement and communicate this throughout the organization? So not even just revenue cycle staff, but any healthcare providers or anybody like that may be involved in anything rev cycle related. The second big thing that we're going to touch on today is automation. And I know it's a scary word, especially if you're a smaller practice and maybe you're, a one-man, one-woman show with rev cycle, you're doing all the work. You want to kind of have your hands on it and you don't want to automate everything. But honestly, we do need to do as much as we can to get full automation, or at least make ourselves as efficient as possible with our technology. And most modern EHR practice management systems, clearinghouses have fancy tools that you may not be aware of that'll make your life a little bit easier. So whether it's robotics, machine learning, big data, and analytics, a lot of these are just buzzwords, but ideally what we're trying to do is just optimize your processes, whether it's claims, payments, denials, AR. How do we get the most out of our system and do things to make our lives easier and not just have like the EHR vendor, like programming stuff from the back end that we're unaware of. I can't tell you how many times as an EHR and RCM services vendor, we've, acquired a new customer and then they have no idea how any of the technology actually works because the vendor kind of set it up on like the back end back in the day. So you want to make sure you understand it, that you're the one that builds any of these processes through the technology to make your life easier. And then finally, if we're going to revisit our processes, remap everything, we're going to kind of leverage technology and AI. Well, how do we know if any of this stuff that we're going to do works? Especially if you're going to have to invest, maybe you're going to buy some AI tools or upgrade any of your software. And you're putting some investment into it. How do you know if you're getting an ROI? And one of the big ways to do that is to check your KPIs against industry standards and against your own historical performance. So we'll be talking about that today. So let's start at the beginning with registration and time of service collections. So I'm going to do all these sections in kind of two phases. One will be best practices, and then the second half will be, well, what kind of technology solutions are out there? A lot of this stuff, guys, is common sense. I would say most of the stuff you've already heard before. These are just great reminders for you, like, hey, don't forget, these are the best practices for this section, and hey, here's some technology that you may want to use. And it may be a couple things that hopefully you come out of these sessions with that you can take back and implement. So let's start with scheduling and patient registration. So best practices on the scheduling side. I've got a few things listed here. A newer one that I'm seeing gain in popularity is self-scheduling. And a lot of folks are kind of scared of that, but I know that in a lot of patient portals, for example, or even through healthcare organization websites, there are now ways for patients to look for and find time slots, request time slots, and you can still put controls in place. Like in Azalea, for example, you can have it to where the practice still has to approve the time slot, or you can have the patient grab it directly, but think about all the time you may spend on phone calls with that right now. Another big one is, since COVID, a lot of technology now includes telehealth, or we've had to find out how to use telehealth. Well, do you have any types of services today that could be well suited to telehealth? And maybe that could limit the amount of time we're spending with like in office routing of people that are coming in and having to do all the, stuff that involves like intake through the office. Would it speed us up if we did some of this stuff virtually? If you're a busy practice, do you have a waiting list? Do you have a policy for no-shows and cancellations? Is that information communicated? Do you have signage up in the office, for example, letting people know? And do you enforce it? And if you see it there, I've got some stats. If you Google this stuff, you can see like what is common. A lot of practices charge a no-show fee, 42% do, which is more than I was expecting. And then also know what your specialty and no-show rates are. And is that something that is a problem now? How do you even know? Do you have the ability to analyze your appointment data and see how often people are calling to reschedule, people are not showing up, things like that? Now, there's also, if you look on the right, some widgets here that if you're a super busy practice, there is becoming a rise in AI intake systems, whether it's like an AI chatbot that patients can speak to that will help them schedule appointments. There's also voice AI agents that I'm starting to see now, where when patients call the practice and they're wanting to schedule an appointment, there's an actual AI tool that can help them schedule it. That is, and some folks think it's scary, but also think about it, because the rise of AI now, this stuff gets smarter and smarter over time. Is that something that you can try out? Does your EHR firm, for example, a lot of times through their API marketplace, will offer tools like that you can try out. So when we talk about data and analyzing it, so you really need to know what your current situation looks like from a scheduling perspective. So even if you don't have an analytics tool like what I'm showing you here that could just spit out a nice looking report that could give you your average no-show counts across time, generally speaking, there is appointment detail reports that you can get out of your system where you get this data in Excel. The important thing is to make sure your staff is trained to appropriately flag the no-shows in the EHR or flag rescheduled appointments and anything like that. So that way, when you do analyze the data, there's stuff there to look at. So make sure folks are actually notating no-shows, rescheduled cancellations, and things like that, so you can sit there and see if this is actual problem or not, because this could affect your staffing. It could affect a lot of your workflows, especially if it's trending in the wrong direction. Now let's talk about visit registration processes. So you remember earlier I talked about mapping out the process. Do you have, especially with the front desk staff, are you leaving them up to their own devices to figure the stuff out, or do we actually have a written registration process that is shared and that we're trained on, that includes like how are we obtaining information like demographics, insurance information, benefits, their medical history, all the consent forms that need to be signed. What are we doing for exception handling? That's a big one that I want to make sure that you notice that. What happens when someone has an exception to your process? Don't leave your front desk staff hanging and having to figure out when someone says, well, I don't have my insurance card, I don't want to pay my copay. when something is happening outside of your typical workflow, how do you want your staff to handle it? Make sure you know what you expect, so then that way it's very clear and they can explain it, articulate it to your patients without having to figure it out on their own. And then you see there's like image of an iPad there. I know a lot of folks say that, oh, well, my patient population, they don't know how to use iPads. You would be surprised, especially folks that wouldn't be technology savvy. They're usually with someone that can help them fill it out. Most of these patient kiosk systems are integrated, so it's removing those steps from having to scan paperwork, which we still see a ton of like paperwork being scanned, wet signatures with actual pen and paper on clipboards. These are pretty standard features now, patient kiosk, iPad options, and I would definitely check, recommend you check those out. So some additional technology besides the kiosk, we've got integrated credit card terminals. Everybody has credit card swipe machines now, so that's not something that is new, but are those systems integrated, meaning when they swipe that credit card for their copay at the time of service, is that payment information routing into your EHR system, or are you having to sit there and hand key it in? Most EHRs have integrated merchant service vendors options. A lot of times they'll match your current rates to win you as a customer. Folks are more and more likely to put cards on file too. So a lot of practices, I think, are scared to ask for a card on file, or at minimum make card on file an available option through your portal, so folks can go ahead and put that on there. It makes them paying your outstanding balances so much easier. There's also AI tools that you can use on the front end. There's a lot of AI that can read images. So like insurance card scanning is a very popular AI tool, driver's license scanning. This replaces the old OCR scanning where some programmer has programmed it to view like each state's driver's license or insurance card, and then it has to be reprogrammed every time the card changes. The AI is programmed to read these cards on their own without updated programming. They can help you auto-populate a lot of that manual demographic data entry stuff. So check that out, because that is definitely becoming more and more popular. So time of service collections, I've mentioned this earlier. Your top payers are now, commercial payers. You may have government payers. The patient now owes more out of pocket than they ever have. You need to start making sure you treat those patient out of pocket dollars seriously, and that we're not just, making sure that the staff knows like, hey, you need to ask for money, whether it's copay, they owe you money from a previous visit, we're going to get a deposit for a future surgery. That you actually I would recommend preparing scripts and talking points for your staff, and including those exceptions that I mentioned earlier, like what is your official policy if they cannot pay? So I hear a lot of times folks saying, well, hey, just bill me for it, I don't have my money. You could say something like, okay, sir or ma'am, we will do that today, but just know next time we will expect you to pay up front. So you can, give a little bit, but also make sure that you're being firm. And I definitely recommend, if you don't ask, you won't get paid. If you wait and try to balance bill after the visit, the chances of you getting paid drops dramatically, and you know that. So now let's talk about charge capture, coding, and claim submission. So it's important that, and this is where you get the providers involved, making sure documentation is complete. Does it support the CPT codes? I suggest doing mini audits every so often, and if you're not comfortable doing that, there are firms that you can come in and have them read just a certain subset of charts. Also, best practices, these charts need to be signed within 24 or 48 hours of the data service. And that is one big thing that is going to hurt and create revenue leakage. Incomplete documentation, charts that aren't signed, coding as well. Maybe the documentation is pristine, but the coding is not accurate. Look for coding tools, integrated coding tools, whether it be claim edit tools, AI charge capture, AI autonomous coding. Especially if you're a busy practice that does a lot of repetitive type things, there are AI coding tools out there that can read documentation, suggest codes. There may be just existing features, again, that your EHR offers that you may just not be aware of. And please stop using paper super bills or two separate systems. If you're using an EHR, it may be a difficult conversation, but if it's tied to cash flow, like, hey, it's best practice to input your codes into your chart so they cross over for billing, and let's stop circling paper or creating paper super bills that have to be turned in. Those things could get lost, and I can't believe how often I still see it, even when you have a big practice that's a big money maker, a lot of times they're still more comfortable filling out paper super bills. So here's some technology you can use here. I kind of touched on some of these, and one of the biggest revenue leakage charge capture situations I see is when providers who have a traditional office or set of offices are going to do rounds outside of the office. Maybe they're going to hospital, nursing home, and they still have to bill for those visits. A lot of times we're getting face sheets, super bills, information printed out of the local hospital or nursing home system where we're physically carrying that back to the office. Most EHR systems today have mobile applications that are designed for charge capture, where you have your patient list that you can pull up. You can add the codes, create quick pick lists of common codes, carry codes forward from previous visits, and even take pictures of face sheets and things. So that way it's all integrated and charges don't get missed. Also, like simple stuff, let's make sure we're integrated with the clearinghouse. Please tell me you're not downloading 835 claim file or 837 claim files to your local workstation and then uploading them to the clearinghouse. Make sure that it's a direct integration and that you're using with a clearinghouse that's integrated directly with your PM or EHR system. And then at the clearinghouse level, a lot of them have predictive denials, and sometimes you can get that even in your billing application, where it will look at historical claim data across a huge data lake of clients of similar specialties in your area, and it could say, hey, based on the way you filled this claim out, there is a 15% chance it'll deny. If you don't have anything that fancy that's available to you, or if that sounds something that's too expensive or not needed, you can also, most systems now have custom alert rules engines where you can build your own alerts and make sure that if a modifier, a prior auth, or anything at the charge capture claim level is required and it's missing, that your system is actually reminding you to do it, so that way you don't have to remember all these rules in your head or have them written down somewhere. So some benchmarks that we can use to kind of grade our performance here on all this front end patient registration, time of service collections. There's many different ones. So I'm just going to give you some that I like, that I've used over the years. And some of this depends on what your reports can give you, what data you have access to. But EDI rejection rate is a good one. Like, how often are your claims rejecting at the clearinghouse level? Less than 4% we would consider best practices. And then again, that's a good reflection of how well you're performing on those front end processes. Same as average days to bill, like how long on average does it take from the date of service to get that first claim out the door? You would be surprised actually that it's about 10 days standard. I would say less than 8 days is good, but really like the high performing practices can get them out same day or often within 2 or 3 days of the date of service. But that's an easy one to calculate as well. A lot of these, if you don't want to sit down and calculate them, or if you can't find a report that has them, the clearinghouse that you use will generally have these KPIs available. Time of service collections is a big one too. I'll spend some time talking about like exactly how you can pin that down, but you really want to be able to calculate and keep track of how successful we are collecting at time of service. So speaking of that, what I like to do is get the data on total encounters, total payments. Can we take payments and decide how much of this came from a patient? And if so, can we split that between time of service payments that are made up front or payment on account, meaning they've paid after they've received an invoice? Some of this involves making sure that you have the transaction codes, that you're using transaction codes correctly in your billing system, and that your staff is using the correct transaction codes when they record a time of service payment from a patient versus a payment on account. If you're not disciplined about that, it's going to be hard to separate them. And even if you can't, you could still divide total patient payments by visit count and get that patient payment per visit number. And if you see here, I like to trend it over time. And if you can see, is it improving? Is it getting worse? And you see, I've circled some areas where we had like, wow, we had a bad month, especially compared to prior months. And the only way you would really know that is if you're trending this information over time. You could compare, your current numbers to prior numbers. And if there is a bad trend or a negative trend, that's where we dive into the details. We might need to do some additional training. But you got to have the data. Average days to bill, same thing. Trend it over time and look for outliers. In this case, we might say, hey, look, if we were just looking at March or February, you might say, hey, that's actually not too bad, 8 or 7 days. But then if you look historically, you would say, This is actually a negative trend. We were getting out faster. This means our cash flow is going to be disrupted because we're slower getting claims out. From there, drill into the data. I mean, this is a real life scenario. This is not real data, but we actually had years ago a client that had, multiple locations, several locations that they had just acquired. They were a multi-specialty group, and it turns out their days to bill started going in the wrong direction, and we found out it was because two of their locations had staff that were slower than the other locations. It turns out they needed to do some retraining because these newly acquired practices had less than ideal protocols. And then we've also seen it where there was one provider, for example, that all of a sudden started getting behind with signing off and completing their documentation. And that was the reason their average days to bill fell behind. And the only way to really know that is to look at the data. Finally, I was just going to throw this on here real quick. If you just Google this, the AAPC has a free tool. So if you were worried about charge capture, maybe from an E&M level, and you wanted to make sure that you're not overcoding, undercoding, things like that, this is a really easy way. I would recommend doing this once a quarter at least, maybe a couple times a year, just to make sure, because you may not be getting audited today, but if you have a pattern, and I've seen before where EHR systems were optimized the wrong way, programmed, next thing you know, we're billing out 95% of everything at a level 4, which is crazy, but I've seen that before. And then 3 years later, you're getting the audits and they come back and they start retracting money. So you may not notice it right away, but you need to be checking for this periodically. So now let's look at payment processing and AR management. So some best practices for posting payments, which a lot of folks treat this as like, oh, this is the easiest part of the rev cycle. I'm not going to spend a lot of time thinking about it. But here's some best practices, because it really can create some downstream negative effects if we're not posting payments frequently. So let's not wait till the end of the month to post everything, or let's not just post payments once every couple of weeks. I would recommend at least daily we're posting payments, especially pulling remits from the clearinghouse to post. That way you're not stuck in a situation where you're out of balance and you're reconciling, and because you went too quickly and you posted everything too fast. So let's post those payments on a recurring basis pretty quickly, and make sure that we're actually, so whether we're auto posting, which we'll talk about in a minute, or we're manually posting, that the denials are being recorded correctly. Do not just take like a printed piece of paper that has a denial, or printing the page with the denial on it and setting it aside to come back and work later. Record the denial information in your EHR so you can use the denial management tools there, or even in the clearinghouse to come back and work those denials pretty quickly. You want to turn those around within a couple days of the denial hitting the system. We also want to make sure that when we do post, we're matching payments, that we're reconciling, especially when you think of like virtual credit card payments, where a lot of times you have to process that virtual credit card, and if you forget, you're not going to get the money, but you may actually post it like it's a payment in the system. I see that all the time. I would recommend reading the fine print on your VCCs, contacting your payers and getting those converted to either ACH or EFT. They don't want to do that, but I would definitely recommend doing it. You can get it done. It may be a little bit of a pain at first, but once you get those VCCs turned off, it's going to make your life so much easier. Closed period. So the final piece is, hey, we're posting payments. We are, getting everything reconciled. Charges are in. We need to close periods. I do RCM analysis all the time, and one of the things I see a lot of is that the periods are all open, meaning staff can go in willy-nilly and change things from a year ago because we're not closing periods. There's no checks and balances in place. Close your periods. It requires discipline, and payment posting is a big part of that, but it's definitely best practices. All right, some things to automate the payment posting process. 835 auto posting, it's obvious. A lot of folks don't like how some 835s auto post. Maybe they're adjusting stuff they shouldn't. Maybe they are rolling stuff to patient responsibility. What you're seeing more now is adjustment rules engines, where you can actually program a rule, not having the software company do it, but you can actually go in and program a rule that says like, hey, from now on, when this 835 for this Medicaid plan posts, I don't want this situation to roll to the patient. Or for RHCs, we see this a lot where they have bundled services and an AIR reimbursement where the bundled services need to be adjusted. And maybe when you auto post the 835, it doesn't do the adjustment the way you want. in many cases, you can actually override that and write an adjustment rule to fix it. So that way you're not having to manually correct it every time. Also, let's reduce the checks, the paper checks that we're getting. You're not probably going to be able to get rid of all of them, but in many cases, you can convert paper checks to EFTs. You'll get the money like a week faster than if you wait for a paper check, and it makes it easier to reconcile to your bank. A new tool that we're seeing more and more of is EOB to ERA conversion AI tools. Those are like, so you're still going to get payers. There's a lot of Medicare supplemental payers, for example, that still just love to mail you paper EOBs and paper checks. Well, there are a lot of AI tools. Azalea has one that could read a paper EOB that's either scanned or a PDF and convert it to an 835. And they're getting more and more accurate all the time. Definitely check that out. Robotic process automation is also a big one. So if people are paying you online and you have an integrated online vendor, in many cases, there's a RPA bot that can be programmed to automatically post the payment to the outstanding charge line. So you're not having to physically post those payments that folks are making online. So really a lot of neat things there that could speed you up. You just got to sometimes you got to slow down in order to speed up. So you may have to spend some time investigating these tools and making sure you know how to use them. So now let's move over beyond payments, because not everything's going to be paid. I'm not sure if I mentioned this before, but denials increasing is becoming a thing with AI. AI is great for us because we can use AI tools to make us smarter for billing and speed us up. But, just know that the payers are using AI too. And there's been article after article out there about, different commercial insurance payers, for example, using AI to increase denial rates. So actually, we're starting to see a trend of increased denial. So it used to be like, hey, 5 to 10% denial rates, pretty average. Now we're seeing 10 to 15% denial rates becoming the average because of these tools. So we have to be able to combat that. And here's a list of the top denial reasons. Depending on how your practice operates, you may not have a lot of authorizations, but if you do, think about how much time it takes to fix a prior auth denial. You may have to get the provider involved. You may have to get the prior auth staff member involved, and all think about how much their time is worth, your time is worth, and how much time you spend fixing these denials. You can Google these stats. So these are, think of how many denials are preventable, and think about some of the tools we mentioned earlier that I'll talk about again that you can use to prevent these from happening. So first thing is the best practices, and that is, do we know what our denial ratio is and what is our clean claim rate? I've got the formulas right there on the screen. Do you have any resources internally where you've put down like, hey, when this denial happens, here's what it means and here's what you need to do to fix it? And here's just an example I created. It's like a Google Sheet. You're probably using G Suite, Microsoft, and there's a shared application where you could create like a set of resources that are shared throughout your organization. Please make sure you're doing that, and that you're not using like an Excel sheet or a Word document that you're emailing back and forth, or anything that's like printed on paper. Use like a centralized location to share this information and make sure that everybody has it. Even if you're the only one working denials, you're going to see denials sometimes, rarely, but then you're going to forget, like, wait a minute, what do I do to fix this again? So put some detailed instructions, especially you may want to differentiate per payer, per state, things like that, because certain denial claim adjustment reason codes might mean different things depending on the payer. And then from there, like, hey, how many denials are we seeing? Do we have the appropriate staff and the time? The first thing that falls by the wayside when we are behind on RCM is working denials. That's why so many of them go unworked from the previous slide, is because you got to get the claim out the door. That's a priority, right? You got to submit the claim and get them out, because otherwise nothing is going to get paid. Then we got to get the payments in the system a lot of times, so that way we make sure that we can balance bill our patients. But then a lot of times we just run out of time. There's only so much time in the day, and next thing you know, there's denials that just don't get worked. So we need to make sure, like, hey, do we have enough time, resources to work these denials? Are we making sure that we're identifying recurring denials? And do we have the staff and the time to actually touch them? And are we communicating? So not like, hey, let's not just fix it and move on. If it's a recurring denial, are we communicating this? So if it's something that is happening at the front desk, maybe the providers are doing something with coding that's creating denials. So make sure you're using analytics. Most clearinghouses, PM tools can give you denial data like this, where you can see like how much of my gross charges each month are denied, what are my top denial reasons, and what kind of category level are they, so that way you can go back and make those changes. So AR follow-up, best practices. So this one is the most time-consuming piece of the rev cycle. This is where we can get the most bang for our buck using technology and not just like picking up the phone and calling the payers. We need to have a strategy based on payers, aging buckets. Let's not just start grabbing AR items at random. You got to know who your payers are. What are their timely filing limits? What are their prior auth requirements? Do you have your contracts with your payers? We'll talk about that in a minute. And do you know what to do for each payer? And do you have a plan on when you plan on grabbing a denied item or an unpaid item? I recommend coming up with a touch cadence. So know who your payers are, what the timely filing is. That will tell you then how quickly do I need to start touching these AR, and how far do I wait 30 days? Do I wait 45 days? Or if I know Medicare takes 2 weeks on average to process a claim, should I start waiting until maybe that 15th day and then start following up? And then appeals library. Let's not just hand type an appeal every time one comes up. Use ChatGPT, use online resources, save your appeals library, repurpose them. And then I also like to say, if you're getting frustrated and worn down by working AR, start with your easy fixes, build some confidence. So go to the AR items that you know how to fix pretty easily. Maybe it's Medicare claims that are like medical necessity, and you know how to look up the medical necessity guidelines really quickly, and you have the resource for it, and you feel really good about that. Fix that stuff first. Get some confidence, build some steam, and maybe the high dollar items. So that way, if you do end up spending 30 minutes or more on one AR item, you're doing at least for the stuff that is worth the most money. So there are action dates, tickler systems in software systems these days. They can remind you when it's time to start following up. So that Medicare example that I mentioned earlier, where it could be payer specific. If you know how long it takes them on average to process a claim, you set that reminder for the day after that date, or at some point right after that, so you're following up really quickly. Can you build work queues in your system? Most of the time you can. Let's build a pre-built work queue of my billed but unpaid Medicare, billed but unpaid secondary claims. So that way you're not running an aging report, which becomes outdated pretty quickly. You're working this stuff in real time. A lot of clearinghouses now offer real-time claim status inquiry, where they're actually going to ping the payer through an electronic connection. That's going to keep you from picking up the phone or even having to log into a payer portal. So check that out. TriZetto is a clearinghouse that we work with. They have real-time claim status inquiry. We basically program it, or you can push a button. And for most payers, it will ping the payer and bring you back information on what happened with the claim. And then again, I've mentioned AI-powered appeals and resolution, and then close the gap. So if we're seeing repeated problems over and over again, how do we get it to stop happening on the front end? And then let's look at our buckets. So I recommend you run your aging reports, you get those summary totals by bucket like this, and you look at it not just in terms of dollar amount, but what percentage do you have in each bucket? And then you're watching that trend over time, because in this example, look at that money that shifted to the 30 to 60 bucket several months ago, and you could tell that money continued to flow over until now all of a sudden it becomes a 121 plus bucket. If we had been watching this earlier, we would have caught it early in the 31 to 60, and that's when you drill in and start looking into the fine details. That's when I would go and run my aging report and see, well, what payers, what's blowing up my 31 to 60 bucket, because it's generally going to be like a certain payer, a certain set of procedures, some claim files that didn't make it to the clearinghouse that happened that caused that chunk. And if you're not watching it like this and looking at the trends, the stuff's going to end up aging out and you're not going to get paid for it. So then reporting and analytics can help you with this as well. So are you having to run reports manually, put them into a spreadsheet? Are you spending hours on that? Or do you have an analytics tool that you could take advantage of that breaks down each month? Especially I like this one because it gives you for each month gross charges, how much was paid, how much was contractually written off versus non-contractual. If you start seeing some non-contractual adjustments increase, meaning it's been written off and nothing was paid, you want to do a 100% adjustment report, or basically you're finding a report where the write-off total equaled the gross charge, meaning the entire thing was written off. That's where you're going to find some recurring themes, maybe some denials that weren't fixed that were just adjusted. because some folks will just write things off rather than follow up with them. And that's one thing you could do on a routine basis. And you have to do that as an audit. So you may not do that every day, but you're doing it on a recurring basis. So here's some KPIs that you can use to track. Again, there's a ton out there, but these are the ones I like. Denial rate. We talked about, what's considered average. That number is moving up now because their payers are getting smarter about using AI to deny your claims. So you need to be able to track that. You also want to know what is your days in AR. And here I've got some best practices at the top of what I think could be considered a good KPI. But you need to be able to calculate this. And even if your KPI is not considered desirable at this moment, trend it over time. Is it at least moving in the right direction? I also like looking at the 120. Some folks like looking at 90 plus, 120 plus. But let's make sure we're not seeing a bunch of our AR getting into those older buckets. And then I also like to look at the current bucket. So let's look at what's less than 60 days. We want the bulk of our money in those earlier buckets. So finally, we're going to wrap up with the back end patient collections. So please stop sending paper statements for everything. Let's look at e-statements. I get e-statements and text all the time now, and I'm familiar with it. Patients are more and more likely to pay. Even in most systems now are set up to where, hey, you're going to get the text, but then you're going to then get a paper statement or an e-statement after it. But the text is kind of priming the patient to let them know, hey, you owe money. You can either pay it now or you can wait for the bill to come with mail. Make sure you have online payment options. Stop having your patients mail you paper checks. Those are easy to set up. You just got to sit down and do it. Your current vendors have these options. Make sure you have an official policy on if you're going to allow for payment plans. What does that look like? And also have a policy on what you're going to do if patients don't pay. So are you going to use a collection agency? Don't just write it off, because if your patients find out that you're just going to allow for that and you're not going to take any further action, then they're going to be more incentivized not to pay your bills. Some account maintenance best practices. So I mentioned these are some things holistically that you need to do that are outside of just those individual items. So I mentioned closed periods earlier. That's best practices. Making sure that we're watching credit balances. I've seen practices that were looking to be acquired by larger health systems that had never worked credits, and they ended up with hundreds of thousands of dollars of refunds that were due to patients that they had just never bothered to process. Well, guess what happened when it was time for that acquisition? That money got subtracted, and the partners had to divvy that money up, and it really, I've seen it in real time wreck like an acquisition, these credit balances that never get worked. So make sure, because that's where you're going to find issues with, are we over collecting? Are we posting stuff incorrectly? And these are not really credits. We've just got a problem with how we're posting. We also want to make sure we're looking at our fee schedules. Do you have your payer contracts? If not, find them, get them, go call your payers, go to your portals, pull your fee schedules, compare them to other payers, find out who's paying you the most, who's paying you the least for all your top CPT codes, and then make sure you're auditing yourselves. And I mentioned audits all throughout, whether they're HIPAA compliance audits or 100% write-off audits. This stuff has to be written down. You need official policies, okay? If you have employees working remotely, do you have a HIPAA compliance plan for that? Are you able to make sure that they're following the rules the way you want them done? Are things centralized? Do you have coding compliance in place? You may need an outside vendor for that to come in, a third party, and make sure that, maybe once a year we're doing those mini audits on our documentation, our coding, and that, some of this stuff could be done annually, but we also want a plan. And the more organized you are, the less likely you are to run into any problems with this stuff. All right, so that's all we have for today. Thanks for spending time with me and listening to all that I had to share. Hopefully you got a lot out of this. If you have any questions that come up after the session, please feel free to reach out to me directly. There's my email address, doug.swords@ahealth.com. And if you're thinking about how some of these ideas apply to your organization, you want a more tailored, detailed conversation, I'd be happy to connect and talk with you. So thanks again, and we hope to see you again at a future session.